Thank you, Dr. Charlie. That was great, as usual, phenomenal. Now, I would like to introduce Dr. Herzog. He's the director of our cardiac care unit. He's an associate professor of medicine in Columbia University, and he'll be talking to us about that escape pathway that you heard me alluding about. Aya?
Thank you. So, my goal here is to take most of you who are not electrophysiologists, who are not echocardiographers, and by the end of the next 15 minutes, that you will be able to say who needs a defibrillator and what kind of defibrillator to provide to the patients. Who is playing my slides? Someone is moving my slides. You mind?
Not me.
It's definitely not me.
Here, all right, thanks. You know, thanks. You stay up. No, I need the makeup. He was fixing something. Here you go.
Okay, so a few years ago we introduced the escape pathway. Like most of our pathway, it's an abbreviation, it has a meaning, and hopefully you can remember it. Escape, evidence-based novel pathway for low ejection fraction and sudden cardiac death awareness and prevention eligibility. Okay? Sounds complex, but I'll make it very simple. So what are our objectives? We want to demonstrate that implementation of a simple, novel pathway for primary prevention of sudden death will lead to the increase in the awareness of sudden cardiac death preventions in physicians who refer patients for cardiac workup. We, at the time when we created this pathway, we wanted to create a registry, which is up to today, we have close to 1,000 patients who meet the escape pathway criteria, and this will include 30 days, 6 months, and 12 months follow-up. So, what is how we did this algorithm? The two main key differences of our pathway compared to prior reported algorithms, which exist in other institutes, that our algorithm starts in the imaging laboratories. The registry consists of consecutive patients who are presenting to the imaging laboratories, including the echo, the nuclear lab, and the cardiac catheterization laboratory. And the activation of the algorithm is actually initiated in the imaging laboratories. Just the opposite what you think as a clinician if you start with your clinical exam. We, in the imaging laboratories, will tell you, you maybe belong to this registry. The inclusion criteria, all adult patients, age 18 and above, who present to one of our imaging laboratories with ejection fraction of less than 35%. By the end of this section, I want you to remember three things. One is this number, 35% ejection fraction, and two more things that you're going to see shortly. Now, if you have patients who are above the age of 75-year-old, we are going to discuss the benefit of ICD in such population of patients because most of the clinical trial excluded this group of patients. Very simple exclusion. Patients who do not speak or read the language of the consent, patients with altered mental status, who are unable to understand the consent, homeless who cannot be followed, and patients who refuse to participate. Very simple. So these are the three questions. If you memorize one thing, remember these three questions. And if you put all the three questions together, you will know who needs a defibrillator. The first question, what is the left ventricle ejection fraction? Second one, what is your heart failure functional class? And the last question, was there an evidence of prior myocardial infarction or coronary artery disease? three things: ejection fraction, heart failure symptoms, and history of coronary disease. If you answer the question of these questions, you will know the answer. Do you need a defibrillator? And what kind of defibrillator you need. This is how the algorithm looks as one page, and I'm going to go through all the details of how we get this to the conclusion. Let's start at you've seen many of our algorithms. By now we have 9 different algorithms. The top third of each algorithm is actually how you identify the patients. And the bottom 2/3 of each of our algorithm is how you treat the patient. So let's start with the top of this algorithm up here. So, Farouk, myself, or Dr. Rozansky in the nuclear lab, someone reads any imaging study, and we report ejection fraction lower or equal to 35%, we tag you that you may be able to be in the registry for the patients who need a defibrillator. Now, immediately we want to exclude 2 groups of patients. These 2 groups of patients are patients who anyway need a defibrillator, which I'll outline in a second, and the second group of patients that you are not going to put a defibrillator. So what are the patients that there is definitely indication for secondary prevention? Secondary prevention in the field of defibrillators, meaning that you already had an event and you do not want to have another event. The patients who anyway needs a defibrillator for secondary prevention includes the patients who had sudden cardiac arrest due to ventricular fibrillation or ventricular tachycardia, patient who had sustained ventricular tachycardia, unexplained syncope, high-risk disorders like Brugada syndrome, long QT, HCM, ARVD, which are not the topic of this discussion today. These patients do need secondary prevention. Our algorithm is for primary prevention. And you want to exclude people who have a contraindication for a defibrillator. And these are the major exclusion. Patients who are in New York Heart Association class 4, unless eligible for CRT. Patient with cardiogenic shock or hypotension. Irreversible brain damage from pre-existing cerebellar disease. And patients whom we believe that their survival will be less than 1 year. This patient will not get a defibrillator. So now, we excluded the patients who are secondary prevention, we excluded the patients who are contraindicated, and we asked the second question. Second question was, do you have heart failure symptom? And let me simplify it even more. I give you 2 ways to define heart failure symptoms. If you look at the bottom here, there are different classes, class 1, 2, 3, 4, very easy to memorize. Class 1, no limitation of physical activity. Class 2, slight limitation of physical activity. Class 3, marked limitation. And class 4, unable to carry out any physical activity without discomfort. Or if you look on the right, in the middle portion of this algorithm, another definition, 1 is asymptomatic, 2 with mild exertion, 3 moderate exertion, and 4 symptoms of heart failure at rest. So you have to ask the following question. We know already you have ejection fraction of less than 35%. Now we want to know what is your heart failure symptom. So you actually have to talk to the patient here. So this is why we flag the patient by the imaging laboratory, and then the physician or the provider, does not need to be a necessarily physician, figure out what are the symptoms. Again, so this is the first question. The second question, did you have evidence of myocardial infarction? So let's now talk about class 1. Class 1 are patients who are asymptomatic. This group of patients, you want to ask now the third question. Did you have evidence of ischemia? Did you have evidence of myocardial infarction or prior event? If, and it's on the left side of this algorithm, you had a myocardial infarction less than 40 days, or you had an elective PCI or coverage of less than 3 months, you will not get a defibrillator. There are many clinical trials to support this idea, but the concept, the idea is that there is a possibility that your LV dysfunction will improve after the time frame that I just mentioned here. So what happened? You have to reevaluate this patient. For the MI is after 6 weeks after the event, for the elective PCI coverage after 3 months. If follow-up imaging modalities will still show ejection fraction, this time less than 30%, this is how the guidelines work, So if you remember the 35, it's enough. But for this group of patients, you need to be less than 30% to meet criteria to get a defibrillator. If your myocardial infarction was more than 40 days ago, and you have EF of less than 30%, you will get a defibrillator. What happens if you have now class 2, 3, or class 4? It just happened at the time when we actually designed this algorithm in 2009 that clinical trial have proven that this will be beneficial to ischemic and non-ischemic cardiomyopathy, so you immediately put in the algorithm. So practically, it's good even if you have a history of coronary disease or you don't have coronary disease. The key here, and remember, class 2 is with minimal exertion, class 3 with significant exertional activities that you get your symptoms. The key here is maximal medical therapy. And optimal. When we started it, it was maximal. Guidelines have changed, and now it's called optimal, because not all patients can actually get to the maximum dose of beta blocker or ACE inhibitor. So the wording we're using now is optimal heart failure therapy, meaning your patient, what's the maximum dose the specific patients can obtain in order to improve in symptoms. And the 4 medications per guidelines that need to be provided include ACE inhibitor, beta blocker, if indicated, spironolactone, and statins, treatment for heart failure. If your patient getting his optimal heart failure therapy for at least 3 months, and there is no improvement of ejection fraction, and the cutoff by the guidelines here is 30 to 35%, you meet criteria for defibrillator. If you have class 4 heart failure, I mentioned one exclusion, but there is one group that may be included. This is what Dr. Chardy was just earlier have shown to us. These are the patients who have a wide QRS complex exceeding 120 milliseconds, and this patient will get CRT defibrillator. So, somehow I cannot go to the prior slide to show the entire algorithm, but if you summarize these 3 questions, ejection fraction, heart failure symptom, evidence of myocardial infarction, yes or no, and repeated studies, and taking your medication in optimal therapy for 3 months, you meet all the questions we need to know if the patient needed a defibrillator. And unfortunately, what Imad have shown you, and it's submitted to publication now to a journal, that in our database, in almost 1,000 patients, only 19% actually eventually, even though we tag them that they have the low ejection fraction, eventually got a defibrillator. So there's a major gap, and this is why we need your help to improve this gap. And this is one of the tools that we are producing here to improve this gap. Obviously, I have to promote one thing that most of you have seen. There's a very good book. I saw it on sale on Amazon now. But there's a very nice chapter about how we define if someone needed a defibrillator. All the pictures are in this book, in chapter 19.